Good afternoon, everyone. So initially, the title is supposed to be atrial fibrillation and related arrhythmias. It came as atrial fibrillation and other arrhythmias, and I am going to talk about atrial fibrillation and flutter, so none of the other. So I am charged with the task of talking to you about atrial fibrillation and related arrhythmias. Now, what do we mean by this? Atrial fibrillation is an abnormal rhythm, but there are many rhythms that are abnormal in the heart. Some of them are more significant than others. And it would be a very hard task to talk to you about atrial fibrillation and all the other arrhythmias in a constricted period of time. The heart activity is normally started by electrical impulses that come from this part that I am pointing at. This is the normal pacemaker of your heart. That is the piece of tissue in the heart that's supposed to give the pace to the heart. And the electrical activity starts there, goes to the rest of the heart, and the heart moves. And that happens about 110,000 times per day. Give or take. Now, every impulse that happens in the upper part of the heart is supposed to travel to the lower part of the heart through this depicted branch of conductive tissue, and not by anything else. That's the only piece of tissue that connects the upper part of the heart with the lower part of the heart. As you can tell here, the lower part of the heart is a big part, very muscular, very strong. That is the part of the heart that pumps the blood mostly, with some help from the smaller chambers that are up there. But this is the real pump. When the upper part or a smaller part of the heart contracts, it creates a small electrical blip that's followed by a big one, which is the big part of the heart, and that's the normal rhythm. And this is a normal rhythm. We call it sinus rhythm because it comes from the sinus node that was the starting point. So, small part, upper part, big part of the heart. What's AFib? What's atrial fibrillation? Atrial fibrillation basically is total chaos in the upper part of the heart. In the upper part of the heart, the electricity stops having any kind of order, and it starts to be completely chaotic. There are multiple wavelets. There are rotors circulating in the atrium. There are wavelets meandering around the atrium. There is no order, there is no organization. And that's the distinctive feature of atrial fibrillation. We cannot tell if it's 300, 400, 500, 600, 700, or 800 times per minute. It's just completely chaotic. It's very fast. It's just completely chaotic. In one part of the heart, it may be 300, and the other may be 900, or absolute chaos. Sometimes one of the sides of the heart, the right side, could be organized in flutter, and the left side could be completely in fibrillation. This is important. Electrical remodeling. When this chaos stays for a while, it changes the electrical properties of the heart. The electrical properties of the heart become accustomed or used to the chaos. Our hearts are relatively incapable of going into total chaos. They are relatively resistant to do that. However, when they have been bombarded by very fast and very chaotic activity for a while, they become used to it, and it's much easier to stay in chaos and much more difficult to receive an organized electrical activity. something happened to the color or something. This is just a picture of the atrium with a lot of wavelets and rotors and channels or electrical channels where the electricity can go up, down, sideways, backwards, etc. Now, the atrium goes very fast, and the lower chambers just follow. They are protected, as I mentioned before, they are protected by this channel, this tissue, that allows some of this electrical chaos to pass down and activate the rest of the heart. This is sort of a filter, an electrical filter, or a protection, a natural protection, that allows us to remain alive when in atrial fibrillation, because otherwise the whole heart would be as chaotic as the upper chambers and life wouldn't be possible. This is happening up. Down is just a reflection of what's happening up. Slower, not as fast, but sometimes fast enough to make us feel not very good. Usually the response in the lower chambers is irregular. When it's very fast, you cannot tell. It looks regular actually sometimes. This is a typical EKG. As I said before, the big ones are the big chambers, and the small ones here are the electrical, represent the electrical activation of the upper chambers or the atrium. As you can tell, it's very fast. Sometimes it's not there, it's flat, sometimes it's fast. In any case, very disorganized, very irregular. Now, this is a little bit out of focus, but it's more of the same. What causes atrial fibrillation? Sometimes nothing that we can identify. Sometimes atrial fibrillation just comes. Atrial fibrillation may be present because we have that trait in the family. It's not necessarily hereditary, but there is some familial predisposition. And there are persons, there are patients who have atrial fibrillation without having any other risk factor that can be identifiable, and that atrial fibrillation is just called lone atrial fibrillation, alone, without anything else. However, many times other things are happening that are facilitating or making atrial fibrillation more likely, like high blood pressure, prior heart attacks, weakened heart failure, abnormal heart valves, mitral valve, aortic valve, cardiac surgery. Cardiac surgery is very actually common. 30%, 40%, even of the patients who have cardiac surgery, especially valve surgery, will develop atrial fibrillation. Fortunately, that tends to be a transient phenomenon, and many times after a few weeks it doesn't bother anymore. Alcohol, important. Caffeine. Caffeine has been blamed more than it should, really. For a long time we have been blaming a lot to caffeine. I don't think that caffeine is completely innocent, or at least I am not prepared to tell you that it is. But there are pieces of information that show that caffeine actually has antioxidative properties and antifibrotic properties, and it may not be as bad as it was thought, but that doesn't mean I'm telling that we should drink 5 or 10 cups of coffee. It's just that it may not be the billion that it was depicted as. Alcohol seems to be not very good. Lung disease. People with lung disease tend to have atrial fibrillation, viral infections, sleep apnea, stress, sort of things. I mean, hypertension and hypertrophy of the heart is very common. As I said before, sometimes we cannot tell why. Now, atrial flutter. Atrial flutter is a little bit different, very related. And many people would say, you know, just the same. It's fib flutter, or it's flutter, or it's fib, just the same difference. Not really. There's a difference for those of us who treat the flutter, because flutter is treated very differently at the end from in comparison with fibrillation. The patient may feel the same. The patient may feel just the same. The consequences may be very similar, but the treatment is quite different, so it's worth to make a point of difference. Atrial fibrillation is on the left, atrial flutter is on the right. Probably it takes a little bit of a trained eye, but this is very small and very disorganized. This is very, very organized, except for some movement artifact here, but very organized. And that is the difference. Again, this is flutter, and you probably will not be able to tell this, but these are the big chambers, these are the small chambers, and there is one here and one here, one here and one here, and the same one here and one here. 2 for 1, very, very organized. Flutter is not the same as fibrillation. It's somewhat different, and it's treated a little bit different. Again, more of the same, flutter. Now, atrial fibrillation is almost always, or in the immense majority of cases, started and maintained by something that's happening in the left atrium. This is the heart. These are the 2 upper chambers called atriums, the 2 lower chambers called ventricles, the left and the right. And the left atrium is where fibrillation lives. Now, sometimes it lives elsewhere, but that's the exception to the rule. Atrial flutter, at least the common type of atrial flutter, the common type of atrial flutter, which is what we're going to be talking today, lives in the right atrium. That's a very important difference in terms of treatment many times. Atrial fibrillation is originated from almost always, not always, nothing's always, but almost always, from the junctions of the veins that come from the lungs, these veins that come from the lungs into the heart. Those junctions, those orifices, those hoses plug into the left atrium, and that junction is for some reason arrhythmogenic in some people, and that's what atrial fibrillation starts in the left atrium. Atrial flutter lives in the right atrium, the common type of atrial flutter, and it just circulates, circles, goes round and around. It's a whirlpool that goes around the right atrium, the whole right atrium. Just like this. It can go counterclock, it can go clock, but it goes around the right atrium, and that's what it is. Now, from there, it goes elsewhere, but the main circuit is in the right side, in the upper chamber, in the right upper chamber. So flutter and fib are related. They are kind of similar, but they are not the same. They are not treated always the same. Oops. What happens when someone has atrial fibrillation or flutter? Well, palpitations, fatigue, shortness of breath, chest pain, dizziness, all these things can happen. This can affect the quality of life. You know, you may feel like you are going to pass out, short of breath. The palpitations. What's palpitations? Many people ask, nothing hurts me. Well, palpitations are not pain. Usually they are flip-flops inside the chest. Palpitation is defined as the uncomfortable awareness of the heartbeat. Now, most of the times, there are people who have uncomfortable awareness of the heartbeat, and the heartbeat's beating just fine. That's palpitations, but you know, nothing's wrong. That's not frequent, but some people can feel that. most of the time it will be a fast heartbeat or an irregular heart sensation or a flip-flop or a series of flip-flops or something moving in the neck as a choking sensation. That is what palpitations are felt like. And how do we know that those palpitations or those symptoms are atrial fibrillation? The chest pain, chest pressure, dizziness, palpitations can happen for many reasons, and we know it's atrial fibrillation when we do an EKG. That's the way we know it's atrial fibrillation, otherwise we wouldn't know. It can be ventricular extra beats, atrial extra beats, it could be some other type of arrhythmia completely different to what we are talking about. And EKG is that, and it's confused sometimes with other tests. That's the EKG, and since sometimes atrial fibrillation can come because of valvular abnormalities in the heart, because of the heart being weak, being big, being scarred, being too thick with hypertension. Atrial fibrillation can come because the pressures in the right side are very high in someone that has lung disease, for example. Then we need to see the heart. And most likely what we will do is we will order an echocardiogram, and an echocardiogram will show the heart in real-time movement and the size of the chambers and how the valves are working and the thickness of the chambers. So we will make sure that the heart is otherwise okay, or if it's not okay, well, a plan has to be done to deal with that also. The consequences of untreated or uncontrolled atrial fibrillation are several. The deterioration in the quality of life does not need too much explanation. That is the deterioration in the quality of life. It speaks clearly for its own. Thrombo-embolic events, that's a big and important part of what can happen with unattended atrial fibrillation and flutter. Thromboembolic means clots. Clots that may stay or may go elsewhere. When a clot goes elsewhere, it's called an embolus. When a clot is there, it's a clot, a thrombus. When it goes elsewhere, it's an embolus, thromboembolic disease. So the consequences of atrial fibrillation can be thromboembolic and can also be heart damage because of a very fast heart rate. Just the fast heart rate can whip so fast the heart that it damages the heart, probably because it works so fast for so long, and the end result is heart failure, a weakened heart. Or someone that has a narrow artery for unrelated reasons, if the heart rate starts to be very fast for a long period of time, don't have enough blood to supply an excessively working muscle, and can have a heart attack. That's uncommon. That's uncommon. Most common damage for the most common damage in the setting of atrial fibrillation is because of fast rates for too long. Let's see a little more about this. Thromboembolic disease. This is a picture of the heart, and you see here the ventricles, the lower part of the heart, and you see up here the atriums from the outside. This is the right and this is the left. The left atrium connects to the rest of the circulation in your body, your kidneys, your brain, your bowels, blah blah, the whole body. From the left side of the heart, the blood goes everywhere. This is the left atrium, and you can see from the outside that it has this little part that has the shape of a hood of a little hat. It's a little pouch. It's called the left atrial appendage. And when we see it with ultrasound from the inside, we see it like this. This little pouch here looked from the inside with ultrasound. These ultrasounds done through the esophagus. We put a probe in the esophagus. We go behind the heart, and we can see very well these parts of the heart. And you can see that, well, it's intuitive that this little pouch has blood there that's going to stay there. It's not going to move unless the heart squeezes and moves. If the heart squeezes and moves, this blood's going to circulate. Otherwise, it's going to tend to stay there, sitting without much movement. When the heart's in atrial fibrillation, when the atrium is in atrial fibrillation, when the upper chambers are in atrial fibrillation, the upper chambers have a chaotic, extremely fast electrical activity. They don't move or they tremble. What happens then is that little pouch doesn't have too much circulation, the blood is stagnant, and eventually can create a blood clot right there in the little pouch. And that blood clot can stay there or can move. And if it moves, can go anywhere in the systemic circulation in the body. Anyway, anything. It can go to the bowels, to the kidney, to the brain. If it goes to the brain, it's a stroke. That's a stroke. That clot moved is there, cause damage. So that needs to be prevented. We need to deal with that. We need to be aware of that. The prevention of a thromboembolic phenomenon in the heart is not the same for everyone, but it's actually a kind of a carpet, but not complete carpet, not the same for everything. There are risk factors for clot formation, and mitral disease, one of the valves of the heart, is an important risk factor to form a blood clot. Others are prior stroke or TIA, hypertension, heart failure or weakness of the heart, diabetes, progressive age, 65 and worse, 75, coronary disease, when the left atrium is too big. Female is actually a risk factor for thromboembolic phenomenon in atrial fibrillation and peripheral vascular disease. The addition of these risk factors creates a score, and having one of these risk factors is not as bad, 2 is worse, more is worse. We deal with this, we add up, we calculate. People with no risk factors may not need any blood thinners whatsoever. They may take aspirin, and aspirin might be enough. They may not even need aspirin whatsoever. But that's something that has to be individualized. A big atrium on its own may be enough to give anticoagulation anyhow, even if the risk of a stroke doesn't seem to be that big. But someone that has 2 of these risk factors definitely is at high risk, has to be anticoagulated, or something has to be done to prevent the thromboembolic phenomenon. Long atrial fibrillation, none of those risk factors, a small heart, doesn't have much risk of thromboembolic phenomenon. 2 cases of 30-year-old people with a very big, no risk factors whatsoever, with strokes, teach you that you have to be a little bit careful about not giving anticoagulation to people, even if they have no other risk factors. So thromboembolic issues are an issue. They have to be, people have to be conscious of that. Coumadin or other anticoagulants are not favorites among patients, but many times the problems that they come with are much less than the consequences of a thromboembolic phenomenon. Now, what do we do to prevent this? Almost always what we do is this. There are other things that can be done, but they are exceptional, and we can talk if you have questions about that. But what we do is give medications to prevent clots. Aspirin, really, question mark. really, I don't know if it works. It has been taken out of the recommendations from the American Heart Association. The European Association still has it. Probably doesn't work too much for this. Aspirin with some of the people that you know or yourselves may be taking Plavix or other medications for coronary disease, and those are blood thinners. They are not meant to be for atrial fibrillation, but when combined with aspirin, they do a better job. They do something. They do give some protection, but it's not as complete as the administration of a real anticoagulant. And for many years, for decades, we had warfarin, Coumadin, as the only one. It works pretty good. It converts a risk of 6 or 7% per year into a less than 2% per year, and that's mostly because of not being well controlled. Now there are other drugs in the market, the three of them. You may be more familiar with the commercial names, but those are the pharmacological names. They are similar in what they do. You can take these medications without need of blood tests to control whether they are working well or not. Sometimes they have to be adjusted in dosages, mostly because of kidney function or a small body frame. They are reliably therapeutic. They don't need, again, a blood test to control, but they are not a panacea. They are not just take it, and sometimes there are drug-to-drug interactions, and I would be lying if I tell you that it's all in my brain, all the interactions. I mean, many times we just say, okay, what are the medications, and we have to go to the computer and see the interactions, and if that drug that you are taking for something else is metabolized by some of the pathways that these drugs use. However, the therapeutic window is wide. It's safer than warfarin, probably much more expensive. Almost always these drugs are new, so that's one of the problems. The next problem that I had told you is heart damage. So heart damage almost always comes because of a very fast heartbeat for a long time. So slowing down the heartbeat on its own, slowing down the heartbeat can prevent totally, completely heart damage because of atrial fibrillation. And not doing so almost for sure will guarantee the presence of weakened heart with time. Medications that we use, you may or may not be familiar with, are this, digoxin, beta blockers, calcium blockers, and some of the other antiarrhythmics. We electrophysiologists don't like to call antiarrhythmics to these drugs up here, just to the other kind of drugs that are a little more complex. All these medications that we use to control the heart rate, the pulse, the heartbeat, the number of beats per minute, act here, where I put the black line. They essentially numb or decrease the ability of this tissue to conduct electricity. The electricity is conducted slower. Atrial fibrillation is still there. Atrial fibrillation did not change. Atrial fibrillation is up in the upper chambers, but the effect, the reflection of atrial fibrillation or flutter in the lower chambers is controlled by giving medications to alter the conduction of electrical impulses from the upper chambers to the lower chambers at this level. And some people cannot take these medications because they have side effects. They don't have blood pressure that can take some of these medications, or they don't work for one or other reasons. The medications just plainly don't work, and something has to be done to correct that. We can intervene and put a catheter right there, and we can ablate the AV, the conduction between the atrium and the ventricle. We can eliminate the conduction between the atrium and the ventricle, or modify it profoundly so that it will not conduct very well. The result, as you can imagine, is that atrial fibrillation will be up there and the ventricles will not move and people will pass out. Sometimes can die, sometimes they can pass out. Well, that's not a good plan. Well, this is not done alone. This is done. This is done with a pacemaker. So I receive questions from patients all the time saying the pacemaker is not supposed to control my atrial fibrillation. Well, not really. It's not. The pacemaker, when we put for these reasons, the pacemaker is supposed to keep the heart, the lower part of the heart, the ventricles, the pump of the heart beating at a normal rate, at a normal speed, whatever speed that we program the pacemaker. And the atrial fibrillation is still up there. Sometimes we use mixed treatment. Sometimes we use medications to decrease the conduction, as I was showing in that slide, and those medications work, and they work very good. However, the next thing we know, the heart rate is 30 beats per minute, and the patient feels quite dizzy and short of breath. It's too slow. However, we stop the medications, and the heart goes 160 beats per minute, and the patients feel bad. So when we need to use medications to do this, sometimes we have to use at the same time a pacemaker because the heart otherwise goes too slow by the effect of the medication that's doing good, preventing the fast. So the medications may control the fast sometimes, but they are not as refined as to avoid going too slow, and the pacemaker takes care of that. So that's another way to deal with this and to prevent the cardiomyopathy that comes because of the tachycardia generated by atrial fibrillation or flutter. Now, what about trying to terminate atrial fibrillation and put it back in normal rhythm? That can be done, sometimes cannot, but there are strategies to do that. Cardioversion, this is a machine that we use for cardioversion. We need to anticoagulate before cardioverting to avoid that little clot that's in the left atrial appendage from forming. And once we put the patient in normal rhythm, well, the appendage that I show you, remember, with the clot, well, that appendage will move. And if the clot's there, it will be dislodged. So for this reason, patients have to be anticoagulated. We have to make sure that there is not a blood clot, and then we can cardiovert. Sometimes we do have to do one of those fancy echocardiograms to make sure that in that little pouch in the left atrial appendage, a clot's not present. But what cardiovation does is give an instantaneous strong wave of energy that crosses the heart and basically switches the electricity off. And the next thing that happens is that the electricity comes back, but it's hopefully going to come back as normal. You have the shock, the atrial fibrillation is there, the shock's given, the lights go off, and then the lights come on normally, a normal rhythm. That's what a shock is. It's not a cure. It's a conversion that most of the times a temporary measure. It can be done with drugs. It doesn't have to be done with a shock, but drugs are not as reliable. They have sometimes complications, so it can be done by drugs. It can be done even at home. Some people, when they have a lot of recurrences of atrial fibrillation, can be given a medication that they can pop 3 or 4 of them when they feel the fibrillation and stay home until it converts. Sometimes it will work. That cannot be done when there is heart disease. It has to be a completely healthy heart other than the atrial fibrillation. Now, the problem with cardioversion is that nothing is going to prevent the heart from coming back to where it was. The lights were turned off, they are on, but the atrial fibrillation can come back. Nothing is going to prevent it from happening. Occasionally, I still will do, or people that deal with arrhythmias still will do only cardioversion. And that's usually given to patients that are completely normal heart, that are having atrial fibrillation for the very, 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 very first time. And they have been with fibrillation only for a few hours or days. If that's the case, usually happens after having a few drinks, holiday heart, or after surgery, someone can have atrial fibrillation. Something happened, a pneumonia, something that's transient and cause fibrillation, and we hope it's only that transient environment that's causing fibrillation, and then we do a cardioversion, and the cardioversion may be enough, but that's not the rule. That's uncommon. It has to be a completely healthy heart. There has to be a very unidentifiable transient trigger. It has to be of short duration. Otherwise, cardioversion alone is wishful thinking. It's not going to work. If someone has been in fibrillation for weeks or months, or it's the 5th, 6th times, it's just alone, it's not going to work for very long. So we can do a cardioversion with the help of medications after the cardioversion, or sometimes for a few days before, and then medications can keep the result of the cardioversion to some degree. There are medications that can do that. We use them all the time. Some of them are more potent than others. Now, I'm going to show you some slides that they are not supposed to read. This is a slide that has a lot of information there. I'm not sure if you're going to be able to read that, but let me just guide you a little bit through it. Well, these are just the names of some studies. It's not very important to discuss today. The names of some medications that we use to do these kind of things. And this is how effective percentage of patients without documented atrial fibrillation recurrence at some time, at 8 months, at 1 year, at 1.5 years. It's not forever. It's at limited time. Amiodarone is a medication that some of you are familiar with. Is the most effective and has about a 60% effectiveness, not recurrence, absence of recurrence of atrial fibrillation. The rest of the medications are not very effective. They have about 30% effectiveness. If we are talking about effectiveness, in this case, we're talking about absence of recurrence of atrial fibrillation within a certain period of time. We're not talking about for lifetime. They don't cure, but over time. So they're not very powerful, and the one that's powerful, this one you're not supposed to read, it's too much, but it is, what I am trying to show here is the overwhelming number of side effects of some of these medications. The good thing is these side effects usually are more bothersome than serious. Change in the taste, some tremor in the hands, some people feel a little bit more sleepy, a little bit less energetic. It's cumbersome, it's bothersome, it may decrease the quality of life. It's usually not very serious, and we stop the medication and they go away. When the heart's weak, that's another story. When the heart's weak, when the heart's not normal, some of the medications can be lethal, cannot be used, but some of them can. However, the medication that was more effective, around 60% effective maintenance of sinus rhythm over some time, is the one that has more serious, not very common to tell you the truth, but more serious side effects. Pulmonary, thyroid, and liver. Those are the most important things that can happen with amiodarone. And sometimes those effects are irreversible. Fortunately enough, that's rare, that's not very common, but and usually the effects will go away over months. They don't go away over days. Amiodarone stays in the system and stays in the system. It takes months to get amiodarone out. But most of the times it goes away and things get better. Sometimes don't. Sometimes don't, and there is irreversible liver or lung damage. The thyroid is a given. People with amiodarone will have a decreased function of the thyroid. The thyroid is a gland that we have that controls many things. They will have it. The thyroid will go down in function, and if it does, we know it. We just give Synthroid, which is the medication that replaces what the thyroid is producing. So that side effect is very, very common, and it becomes not very serious since the solution is just like take a supplement that the thyroid does. But side effects are an issue with medications, no doubt about it. So what other things can be done about atrial fibrillation in terms of trying to keep it away and not keep the normal sinus rhythm? Well, ablation can be done for fibrillation and for flutter, and I made a point to make a distinction between fibrillation and flutter because many times they can be treated very differently and the results are not necessarily the same. The most common type of atrial flutter, well, first of all, ablation, what ablation will do is will destroy some tissue with the use of energy, usually heat, and the destruction of that tissue will either interrupt an abnormal electrical circuit, it will either interrupt it, or it will isolate an area that's arrhythmogenic and hopefully prevent the diffusion of that abnormal electricity to the rest of the heart. That's what ablation will do. By the deployment of control lesions in the heart. So, since flutter is more simple, I will start there. Ablation of atrial flutter is done in the right atrium. As I told you before, right atrium is where atrial flutter lives. Left atrium is where usually fibrillation lives and starts and maintains. So ablation of atrial fibrillation is done in the left atrium, and in the right is for the common type of atrial flutter. There are some other flutters that can be present in the left side. They are a little bit more complex. They are quite much. They are much less frequent, and they have a little bit of a different treatment. But the common type of atrial flutter is treated in the right atrium doing this. You have this line here, the purple line, that is created with ablation and interrupts the circuit that rounds around the right atrium. That's done between a ring of fibrous tissue that separates the upper from the lower chamber. That ring that's here where my pointer is, that ring, my pointer is indicating where the ring that separates the upper from the lower chamber is. Well, from that fibrous tissue to other fibrous tissue that's in the inferior vena cava, that's where the lesions are deployed, and it severs that circuit and it doesn't run again. You have a heart seen from the right side, and to orient you, down here is the right lower chamber, and the right upper chamber is just cut open so you can see inside. This is the vein that comes from the legs, from the abdomen to the inferior vena cava. Some catheters are inside. This between this vein plugged into the heart and the ring that separates the upper chamber from the lower chamber, there is a small ridge, a very narrow, well, not very narrow, but a narrow enough ridge of tissue that is present between this lower chamber and this vein. Well, that's strategically perfect to do a series of small lesions and interrupt the circuit that rounds the right atrium and forms the flutter. And a catheter is just placed in that ridge, and lesions are deployed there. The catheter is retrieved a few millimeters, another lesion is retrieved a few millimeters, a few millimeters, a few millimeters, a few millimeters, and lines down. And almost always the catheter ablation terminates flutter and prevents its recurrence. And in three-dimensional mapping, with tridimensional mapping that we do, you can see the right atrium with a line of ablations. All these little dots are burns that come between this ridge and this vein, and the lines formed. The flutter will terminate. Ablation is relatively simple for atrial flutter, for the common type of atrial flutter. As you can tell from the picture here, a catheter placed where the black line is will have to be placed like so in that ridge and just retrieved. It sounds faster, it sounds quicker and faster and easier than it really is, but it's not that difficult. And the results are pretty good, the risks are very low. More than 95%, 95% of chances of permanent cure with no recurrences. And if there is no recurrences, no need for drugs, and in the absence of atrial fibrillation, no need for antiarrhythmics, for anticoagulants either. So ablation for atrial flutter is actually a very old procedure, not very old procedure, but it's old enough, and that has excellent results. It's a very effective procedure. Now, in terms of atrial fibrillation, things are a little bit different. It's not quite so, but it's promising. So, this is the left atrium seen from the inside, and this is the left atrium seen from behind. And these are the veins that plug into the left atrium, here from the inside. The strategy consists in create a circle around those orifices, because it's been shown that from those ostiums of these veins is where the abnormal electrical activity that triggers atrial fibrillation starts. So what we are doing in ablation of paroxysmal atrial fibrillation is isolation of the arrhythmogenic substrate, electrical isolation of the arrhythmogenic focus. This is just to show you one of the pulmonary veins and one of the procedures done. Pulmonary veins, that's how it looks like. Anyhow, so the strategy is this: you have an abnormal heart electrical activity coming out of this location, and by creating a ring of lesions around it, it's supposed to stay there. It's supposed to be contained inside, and that works pretty well for paroxysmal atrial fibrillation. The strategy, the technical strategy, is more or less like this. We come with catheters to the right side of the heart, we cross to the left side of the heart, and we place a couple of cables. One of them is to create small lesions and create a circle, either for each vein or for both veins together, in the left side and in the right side of the left atrium. The left pulmonary veins and the right pulmonary veins, circles around them, and this other is a mapping catheter that tells us when the electricity has been blocked, when it's not coming in anymore or out anymore. We put this circular catheter inside the ostium. So that's the principle how it's done, and that's how we do it. Now, before doing a procedure like this, we usually will order a CT scan. Some places they will order an MRI. We order a CT scan of the heart, and this is a CT scan of the left atrium. That's just the left atrium. The technology allows us to obtain a CT scan of the chest, and we can tag in the CT scan what are the ribs, what's the sternum, what are the vertebrae, what are the lungs, what are different parts of tissue, and we can remove them. And we can be left only with the heart, and we can also tag parts of the heart that we don't have interest on, and we can actually be left only with a CT scan that shows the left atrium. And this is the left atrium seen from behind with the veins that come from the lungs. Once we have that CT scan, we can, and we most of the times do, is we create a real-time shell of the left atrium with the catheter. Just by passing the catheter and touching the left atrium with the catheter, the three-dimensional mapping system registers where the catheter has been, and we have a shell. And that shell that we create in real time, we just overlap with this CAT scan, and then we have the CAT scan to guide us in real time. It's actually quite helpful in order to be able to manipulate the catheters inside the hand. And that's how it looks like when a series of lesions have been placed around the veins. These are the right pulmonary veins, and lesions have been placed around the veins, and this is seen from the inside. We can see from the inside where our catheters are moving there. And this is just the same lesions in the left atrium. So how effective is this technique? It's actually not as effective as atrial flutter. Atrial flutter is 95% effective forever. It's cure forever. Atrial fibrillation, and this is a little bit more complex, and I didn't want to go into necessarily all the detail of this to avoid boring you, but we can discuss it. Atrial fibrillation has lots of atrial fibrillations. There are more than one. Probably not two patients are the same. But when atrial fibrillation is short lasting, it's called paroxysmal. And we can see patients and even doctors that tell us paroxysmal atrial fibrillation for patients who are having once in a while sinus rhythm, and they are almost always in atrial fibrillation. But that's not paroxysmal atrial fibrillation. Or we can have some people tell this patient has chronic atrial fibrillation because has episodes of atrial fibrillation that last for 2, 3, 4 days, and it's been like that for 2 years, and it goes away for a month, comes back for 2 weeks, or comes back for 2 days, and goes away for 2 weeks, and so on and so forth. And it's called chronic. Well, what we call by consensus, and this is a matter of consensus, and it may be changed in the future, but it's the current consensus. Paroxysmal atrial fibrillation is atrial fibrillation that lasts less than a week, and it comes to normal rhythm on its own. No one does anything to it. It comes out of atrial fibrillation to the normal rhythm. That's paroxysmal atrial fibrillation. Paroxysmal atrial fibrillation is paroxysmal, and it's not long-lasting. When atrial fibrillation stays for more than 8 months uninterruptedly, or 12 months, it's called long-standing persistent atrial fibrillation. And that's just terminology. It's not something that we invent here locally. It's long-standing persistent atrial fibrillation. And everything in between is just persistent. So we have paroxysmal, we have long-standing persistent, and we have persistent. Now, what do we care about this? Why do we even mention this? It's just semantics, words. Not really. The results of ablation are different in people with paroxysmal atrial fibrillation than people with persistent long-standing atrial fibrillation. The published series worldwide show about 70 to 75% long-term control. I am not sure I want to say cure, because we really don't know if it's cured. But long-term control, and we follow patients for, I don't know, 4 or 5 years, and they are with no recurrences, and that's a common experience elsewhere. In patients with paroxysmal atrial fibrillation, the chances of having that kind of result in the absence of antiarrhythmics is probably in the neighborhood of 70 to 75%, especially with a single procedure. It can be a little bit better with repeated procedures. 2 procedures, sometimes 3. As opposed to the results with long-standing persistent atrial fibrillation. With long-standing persistent atrial fibrillation is the atrial fibrillation that has been there persistently for months, 8 months, or probably the consensus will be 12 months in most of the cases. In some places, 8 months is mentioned. But in those cases, the results of permanent, not permanent, but long-term control and maintenance of sinus rhythm in the absence of antiarrhythmics, of antiarrhythmic drugs like amiodarone and others, the results are variable according to the published series of patients and studies, and they can vary between 25 and 55%. So a realistic number is probably less than 50% of chances, and that is not as good as many of us would like. And that's for long-standing persistent. And long-standing persistent is a problem. Therefore, there are many ways that are done. And everybody does it different. The results are just not as good. But for paroxysmal atrial fibrillation, it's actually very, very effective in 70–75% of people with 1 or 2 procedures. They can be many times free of the problem for, I don't know if forever. I don't know what forever means, but for years. Follow up at 5 years, for example. And that's not only published, but it's a clinical experience of day. So I think I'm going to stop here. I am sure that you may want to talk about something, and just I'll be glad to answer any questions if I can. Yes.
If a short-term gets, why wouldn't short-term be treated before it became long-term? If it didn't go diagnosed short-term and went long-term, or it started short-term and it couldn't be stopped at short-term?
The question is why someone will have long-standing persistent atrial fibrillation. Doesn't it start always as something that's paroxysmal? Almost always, yes. Now, recently, in the last Heart Rhythm Society meeting, there was a very interesting presentation from a German group about a special type of MRI in the heart, and showing that some people with atrial fibrillation start with a lot of fibrous tissue to start with, just from the beginning. So we may be treating different species here. We may not be treating exactly the same. I don't think there are 2 people with the same atrial fibrillation. But in general, you're right. In general, the rule is that patients start having atrial fibrillation for days, for hours, for minutes. And then it becomes longer and more persistent and more persistent and more persistent and more until they are permanently in atrial fibrillation. And it may be because they didn't go to a cardiologist, or the cardiologist thought that they were well controlled and they were just treated with some medications, or I don't know, I mean, maybe the patient didn't follow up, or they didn't have resources to get medications or to get treatments. I don't know. There are many reasons, and sometimes that's a question that I ask myself. But in general, yes. In general, it starts as paroxysmal, and it progresses to long-standing persistent over time. And by that time, a lot of ground has been lost, unfortunately. Yes, ma'am. Oh. Yes, sir.
You mentioned two types of determining this, and one of them was the CT scan and the other was the EKG. What about these stress tests that you go through where they put the radioisotopes through you and do all that checking? Does that determine these different types of problems?
Let me clarify a little bit what I said. We can make the diagnosis of atrial fibrillation with EKG. I will not go there, no way. We can make the diagnosis of atrial fibrillation with an EKG, and that's how we make the diagnosis of atrial fibrillation. There is no better way to make a diagnosis of atrial fibrillation, just a plain EKG, just a plain paper, that's usually a pink paper, that makes the diagnosis of an atrial fibrillation. That thing, that's up there in the screen. Why do we do other imaging? We do an ultrasound, an echocardiogram, only to see if the atrial fibrillation is in a patient that otherwise has a normal heart or a weak heart that is pumping not very good, or some of the valves are leaking, or the heart's thick. So things that need to be treated also, and it's not just fibrillation. So that's why we do an ultrasound. A stress test with radioisotopes is designed to see mostly areas of the heart that do not have enough blood supply. When the coronary arteries do not give enough blood to some areas, usually of the ventricles, of the lower chambers of the heart, not the upper chambers of the heart, but the lower chambers of the heart, when they don't receive enough blood and there is coronary artery disease. And that's why a stress test with radioisotopes is done, and that doesn't have to do directly with atrial fibrillation. People with coronary disease have more atrial fibrillation, yes, but we do a stress test to see if one of the arteries needs to be opened or not, and not to determine how we're going to treat atrial fibrillation. There are isotopes techniques that are used to see the strength of the heart. It's called a Muga study, or basically it's a picture of the heart when the heart's full of blood, the blood stacked up with the radioisotope, and the heart has a size, and the next thing the heart's small, and then all that blood tagged with radioisotope is gone, and the difference between this and this is what the ejection fraction is, and that that's done over 20 minutes. It's averaged, and the machine will give you a number, the ejection fraction, the squeezing percentage of this heart is this percentage. But it's not really to make decisions about how to treat atrial fibrillation. About how to treat atrial fibrillation is the duration of the atrial fibrillation, the EKG that's up there, whether this is fibrillation or flutter, and the echocardiogram that will tell us whether there is concomitant heart disease or the heart's otherwise healthy, strong, and not big, or that is what it is. Yes.
So, Dr. Eguia, I have two EKGs that are brought with me. One, when I was
The second is the one after.
Yeah, this is after.
So what you're saying is your first EKG looks like this,
Correct.
and the second EKG looks like this.
Right.
Right. No, this is normal sinus rhythm. This is normal sinus rhythm. There is no atrial fibrillation here. There is, so once after cardioversion, either with a shock or with medications, after cardioversion with shock or medications, atrial fibrillation goes away. The lights have been I'm not sure how to compare to real life with electrical things in our houses, but basically what happens is that the electrical activity in the heart with a shock has been put down to nothing, to zero. Basically, there was, for a split second, there was cardiac arrest. With shock, the heart goes to a second when there is no electrical activity whatsoever. No normal activity, no atrial fibrillation, no nothing. And then, a second later, something is going to come back. And usually what comes back is the normal activity. Sometimes it doesn't.
So is that electrical shock just overwhelming the heart's natural?
Overwhelms everything. And then something has to come back. And that something is usually the normal rhythm that starts to function. But the process that creates this abnormal electrical activity and the connection between the atrium and the pulmonary veins is still there.
That's what that was my question.
Yeah, the process is not the electrical process, but the tissue process. The tissue process that made the activity spark at some point is still there. And almost always, not always, nothing is always, I don't know what's always, but almost always, the rule is it comes back unless it was an episode of atrial fibrillation that was after a very defined trigger, like too many drinks for one night, or a surgery that someone had, that was something that happened there and it's not going to come back until the next surgery, and it's something that lasted only for a few hours or days. When all these things are together, then many times it's just, one time in a life problem. But otherwise, what's happening is what used to happen in most of the people that have this problem. Most of the people that have this problem, they were paroxysmal, remember? They were paroxysmal. So the problem would last only for hours or days or less than a week. And that's what defines paroxysmal. And on their own, without shock, without medications, without anything, on their own, the fibrillation will terminate, will stop, and it will give way to the normal rhythm. And then a week later, or 2 weeks later, or 5 hours later, the abnormal rhythm will come back. So it goes away and it comes back.
But the potential for it to return is there because the tissue's there.
Right. It's because there is something in this area that makes it arrhythmogenic. There's something there that makes it arrhythmogenic. And 2 years ago, or 3 years ago, or 4 years ago, when this was paroxysmal, it will be there and it will go away. And it will come back and it will go away. And it will come back and go away. We did cardioversion exactly the same. We made it go away. Nothing keeps it from coming back the same as it did 3 years ago, or 2 years ago, or 5 years ago.
So the ablation just eliminates it from ever coming back by destroying that tissue?
the ablation will isolate the tissue that is electrically abnormal so that these sparks will not spread to the rest of the heart. And again, this is pretty good, but unfortunately it's not as good as flutter. It's about 70–75%. And the better it stays, the more it stays in sinus rhythm, the easier it is to get a good result. If you cardiovert someone and that someone goes into atrial fibrillation 5 minutes later or 2 days later, and if that keeps coming back, and the history has been already 1 or 2 years of atrial fibrillation, the chances are not very good. But when someone stays in normal rhythm for some time, the results are better. There is an interesting paper that was published out of Dr. Steinberg in Roosevelt Hospital in New York, published a couple of years ago. And since the results of atrial fibrillation are so different in paroxysmal compared to long-standing, why don't we make long-standing paroxysmals by cardioverting and giving medication and allow some time to go by, weeks or maybe a month or two, and make them stay in sinus rhythm and allow the electrical properties of the heart to regroup and what we call reverse remodeling. And the results were better, were similar in long-standing persistent atrial fibrillation compared to paroxysmal atrial fibrillation, were similar, which is something that has not been like that in any other study. They were similar. The only difference is that the long-standing patients were given treatment to keep them in sinus rhythm for some time, to keep the rhythm organized for some time, to allow the electrical properties of the tissue to become more normal. And presumably for this reason, the result of the same type of ablation given to these patients that were more than 1 year with atrial fibrillation had a result that was comparable to the same type of treatment given to patients that had only days or weeks of atrial fibrillation, which is something that's definitely not the world experience. That was the difference in the treatment, just to put them in sinus rhythm, normal rhythm for a while. Yes, sir.
We have time for one more question.
Okay, all right. Yes.
10 years ago, I discovered I had common arrhythmia. I went to donate blood, and I went to dental appointment, and took my pulse. I was skipping a beat until 4, then skip 1, go 5, skip 1, go 3, skip 1. That kept on going, and then when I would exercise or jog, I would go to a normal beat. And when I stopped exerting energy, I would go to a normal beat, but then I would still skip. And that kept, I went through the stress test, I went to a cardiologist, did the heart monitor, did the stress test on the belt, and everything. So you've got common arrhythmia. My question is, should we keep a close watch on that? Right now, it's been normal for several days. I don't skip a beat right now. My lifestyle may have changed a little bit. Maybe I don't have as many alcoholic drinks. My question is, is there any atrial fibrillation is nothing having to do with common arrhythmia? Is there? I'm not sure what. There is no arrhythmia that's called common arrhythmia. Okay, there is no arrhythmia that has the technical name of common arrhythmia. There are arrhythmias that are common, however. There are arrhythmias that are common. Unfortunately, one of the arrhythmias that's common is atrial fibrillation. It's quite common. It's 10% of the population above 75, and I believe it's about 7% of the population, or 6%, say about above 65. It's very common. I may be off for 1% or for 1 year.
Other common arrhythmias are extra beats, either ventricular, and when I say ventricular, I mean in the big chamber or in the small chambers, extra beats. Okay, that's quite common. When it's in the lower chamber, it's more symptomatic usually. Some people don't feel it. The fact that it goes away with exercise points towards some special type of extra beat that comes from the ventricle, and usually is quite benign. And in those cases, the treatment is indicated only if there are too many of them, like more than 20% of the heartbeats, because that could weaken the heart, or if the arrhythmia is just driving someone crazy because they feel it and they feel horrible. Again, people have palpitations all the time, and they can be many things. They can be binoodal reentry. They can be reentry and due to an accessory pathway. It can be atrial flutter. It can be atrial fibrillation. They can be ventricular tachycardia. They can be extra beats coming from the upper chamber or extra beats coming from the lower chamber. The only way to know is to do an EKG or a monitor and see what type of arrhythmia it is. And if it's just an extra beat coming once in a while from the upper chamber and once in a while from the lower chamber, almost always that's benign, as long as the echocardiogram doesn't show a structural heart disease, as long as sometimes a stress test also shows normality. Sometimes that's unnecessary, to tell you the truth. But in the absence of a structural heart disease, premature beats, extra beats, especially those that are suppressed by exercise, are usually quite benign, and I am not sure if people need to be too worried about. When they start to run a little longer, and they are not just an extra beat or a skip beat, well, then maybe if it's in the upper chambers, maybe it's going into atrial fibrillation. But to tell you the truth, I'm not sure which one was yours.
It was confusing the nurses because they could try to get my pulse with those mechanical types, not the cuff, and that it wouldn't give them an accurate reading, so they had to go to the manual type.
Right.
Yeah. And so, but now lately they've been getting a correct reading with the machine.
Yeah.
And I see where it's coming back to normal. But for 10 years, that was 2004, 2005.
Single extra beats usually are benign, and they do not necessarily progress to something else. They do not. If they start to become very, very common, especially if they start to be single skip beats, they start to do little runs, then probably a complete reevaluation has to be done to see what it is. Yes, sir. Oh.
That's okay, go ahead.
The correct procedure to do is like you're alone, let's say 20, 30 miles from the doctor or hospital. You're alone and find yourself thinking you actually have a heart attack, and all you have is a cell phone in your pocket. What's the correct thing to do?
If you have any abnormal heartbeat, which is a palpitation, usually manifestation of an abnormal heartbeat, usually palpitations. If you have palpitations that are making you feel bad, unfortunately, I don't think that you can be treated at home. Unfortunately, I think that you have to go to an emergency room. If they are what the gentleman said, extra beats here, extra beats there, just go to a doctor, and the doctor will do some kind of monitoring, a Holter monitor, 24-hour monitor, 48-hour monitor, and see what the arrhythmia is. If you're talking about a heart attack is a little bit different. A heart attack is almost always related to chest pain, not always. A heart attack is, there's a nice logo in the Heart Rhythm Society, and the upper part is an apple and the lower part is an orange. And it says, cardiac arrest is not a heart attack. You are comparing oranges with apples. Abnormal heartbeats, irregular heartbeats, even cardiac arrest is not a heart attack. Heart attack in our language, which is semantics, our language, the doctor language, heart attack is when an artery closes. When an artery closes, almost always causes pain or shortness of breath or a sensation of things going very, very bad and a booming sensation.
So should you drive yourself to the doctor, or should you call for an ambulance, or should you lay down?
If you're feeling really sick, you should call an ambulance and go to the doctor if you're feeling very sick.
Lay down, or are you sitting up?
What is the feeling though?
Like a attack type thing, strong pain in the chest, maybe the left arm, that kind of thing.
The easy answer is 1 sublingual nitroglycerin every 5 minutes, and the times 3, and if it doesn't go away, immediately to the emergency room. I don't think you should be driving long distances when that's happening. Someone should pick you up if that's happening. Chest pain, is that what it is? Unfortunately, that's not necessarily the topic of this talk, but, and unfortunately, although I am an interventional, but I am an interventional doctor for these kind of things, and I don't, I'm not saying that I shrink my shoulders when someone has chest pain, because that's the least of the things I would do, but that's not really what people would seek my name for or ask me to help them, unless it's an emergency, of course. Okay?
Thank you so much, Dr. Eguia.
My pleasure.